for this particular lecture. And we have three important learning objectives that I'd like to try to cover with you this evening. Very importantly is how to incorporate a patient-centric focus into evaluating the physical, extranasal, and psychosocial aspects of disease burden for each patient with chronic rhinosinusitis with nasal polyps. We'll also elucidate the best practice criteria for recommending sinus surgery or biologic therapy, or there are other therapies out there for this condition, as we'll talk about, and when systemic corticosteroids may or may not be appropriate. And lastly, we'll differentiate between the new and emerging biologic treatments for this condition using data from clinical trials and other analysis. So let's start first with truly understanding the high disease burden that patients suffer with chronic rhinosinusitis with nasal polyps. This interesting study by Hall that looked at patients with severe chronic rhinosinusitis with nasal polyps, both in Germany and in the United States, looked at what we're talking about here as proximal and distal impacts. And proximal are those that are directly related to the symptoms. So you can see here sleep impact and physical function, nighttime awakening, tiredness. And you can see the vast majority of the 27 patients complained of those problems. And then if we look at distal, and this is really looking more at what we would call health-related quality of life. So emotional well-being, social life, work, feeling annoyed. And you can see here again, virtually all the patients, and in fact, 27 out of 27 said they had emotional well-being problems associated with this condition. Now, there are many tools out there that we can use to measure sinonasal disease. Probably the one most common that is disease-specific is the SNOT-22, or the Sinonasal Outcome Test 22. So 22 being 22 questions. These questions relate to nasal, non-nasal, so sinus problems. It also looks at quality of life issues. So it's a combined questionnaire, and it is standardized, is used in most of the clinical studies. We also have the chronic sinusitis survey, and probably for allergic and allergic rhinoconjunctivitis, and again, it does ask about sinusitis, is the rhinitis quality of life questionnaire. Now, there are numerous generic quality of life instruments, and these can be used for any disease state or condition. And the one that's probably used the most for general health assessment is the SF-36, which stands for short form 36. And this was developed in the United States by Dr. John Ware and the RAND Corporation, and it scored 0 to 100, with 100 perfect health and 0 basically very, very poor health, to say the least. And that measures many things related to mental and physical impairment. We also have the EQ-5D, which comes out of Europe, and then the Global Wellness survey that has also been published. So many different questionnaires, but to be honest, most of these are not easy to use in a true clinic situation. But this one, in fact, I think can be used even in a busy practice. This is a 12-item questionnaire asking about the patient's chronic rhinosinusitis in the last 7 days. So you see here questions that are related to physical symptoms, sensory impairment, and psychological effects. So again, covers all these important patient characteristics, and it has been shown to be validated against the SNOT-22. So I think this is a great way to follow your patients that you're taking care of with chronic rhinosinusitis. Obviously important is the total economic burden associated with this condition. And we all know that these patients do have, and studies show, high levels of having to go to the physician regularly, and obviously the medical treatments associated with it. So the total economic cost is about 5.7 billion a year. And if we look at indirect costs, so not costs directly related to like our care or medication care, but missing work, missing school, decreased productivity. You can see here that the average person with chronic rhinosinusitis nasal polyps misses 4.8 days of work per year. And when you total what it is for the inadequately controlled patient, and unfortunately there are many out there, it's over $7,000 per patient per year. So when you look at the total cost per patient for this particular condition, it exceeds over $15,000 per year. And we're talking about a condition, depending on what studies you look at, that affects up to 7 to 8% of the population. Now, very importantly, when we're evaluating that patient with chronic rhinosinusitis with nasal polyps, we need to look for the frequently associated comorbidities, things like asthma or exacerbatory respiratory disease, asthma, and allergic rhinitis. You can see from this slide how common these comorbidities are with the patients with nasal polyps. But there's another very important point here I want to mention to you, and that is patients with polyps that in fact have these comorbidities, their chronic rhinosinusitis with nasal polyps is worse than if in fact they just had nasal polyp disease alone. So these patients that have these comorbidities, in fact, tend to be some of the more severe patients that we see with this condition. And in fact, this recent paper published this year by Hopkins looked at a survival analysis, 10-year probability of revision. So these are patients that have had sinus surgery, and what's their 10-year probability of having revision? And you see here that it was up to 90% with comorbid patients, but only 51% with non-comorbid patients. So it was up to 4.7 times higher needing a revision if they had a comorbidity. So again, these are some of the more severe patients that we see. So let's look at some of the pathogenic and molecular drivers that we see in chronic rhinosinusitis. And we can divide it into 3 inflammatory endotypes. Type 1, primarily related to the Th1 cell, and the type 1 innate lymphocyte, with the primary cytokines being interferon gamma and IL-12. This is the predominant cause in patients without nasal polyps. It tends to be higher in women than in men, though there are patients without polyps and a fair number that do have type 2 disease, which leads us to type 2 disease, which is the most common associated with nasal polyps. So again, the typical cells, the Th2 cell, the eosinophil, the lymphocyte, the mast cell, and the primary cytokines involved here being IL-4, IL-5, and IL-13. As we know, again, high comorbidities with this, high loss of sense of smell, and tends to be higher in men than in women. And to go back, the type 1 is primarily higher in women than men. And then type 3 is the least common, and this is characterized by Th17 cells and neutrophils and IL-17 and 22. There's patients with and without nasal polyps with this. The group with nasal polyps with this tends to have a high likelihood of having Asian descent, where the type 2 is very high in the Caucasian and African American Hispanic community. Now, this is looking at, and I'm not going to go in details here, the immunopathology of this condition and the current therapeutic targets. But we can see here the epithelium, which gets bombarded with numerous irritants and microbes and allergens. And that can stimulate the epithelium to release alarmins, epithelial alarmins, such as TSLP, IL-33, IL-25 that's not on here. And so these are potential targets to help turn off this immunoinflammatory effect. You'll also notice here there are the CRTH2 receptors, which are found on many different cells, including Th2 cells and eosinophils and type 2 innate lymphocytes. Though I'll be honest, at this point in time, most of the studies blocking this particular receptor have not been efficacious. And then if we look further down, we can see here the role of the type 2 cytokines, IL-5, IL-4, and IL-13. And we know that, in fact, there are, biologics now available that, in fact, do block these pathways for the treatment. We'll discuss them later. And then also IgE, and we have a treatment there also. So a lot of places where treatments could be tried to turn off this immunopathologic process. So with that, let's talk about a patient, because that's what we do on a daily basis, take care of patients with this problem. So this is John, a 41-year-old male. He complains of postnasal drip and decreased smell and sinus pressure and pain. He was diagnosed with asthma in his mid-20s, and he recently experienced rhinorrhea and a seasonal cold. So he's been on over-the-counter intranasal corticosteroids for symptomatic relief for the past 2 years, but just as needed. And for his asthma, he's under control with low-dose inhaled corticosteroids. Endoscopy reveals that, in fact, he does have nasal polyps. So this gets us to our first question tonight. John's clinician orders a CT of the paranasal sinuses and schedules follow-up for John in 30 days. So how would you treat him? Would you prescribe an intranasal corticosteroid for regular use, prescribe a short course of oral steroids and recommend regular intranasal steroids, refer for evaluation of functional endoscopic surgery, or start him on biologic therapy? So let's have your answer now, clicking on the one that you think is correct. Okay, so we really have a split here as far as different answers. So if we look at most of the guidelines, and we'll be looking at some of them, but if we look at what you usually start patients on that have chronic rhinosinusitis nasal polyps, we usually talk about standard of care therapy, which is intranasal corticosteroids and saline solution, and if they need it, a burst of oral corticosteroids. So I think the most correct answer here would be prescribe short course of oral corticosteroids and then recommend regular use of an intranasal corticosteroid. So let's talk specifically about medical management of these patients. So as I mentioned, we have standard of care medical management. So these are usually the first line treatments to try on these patients. They're successful maybe up to 50% of the time, depending on what studies you look at. So again, the intranasal corticosteroid sprays, again, usually using them twice a day. There is also by prescription, the exhalation delivery system fluticasone. We'll cover that in a minute. And then off-label would be things like nasal instillations, drops, things like budesonide respules. For many patients, especially having severe problems, we may want to do a medical polypectomy. And what we mean by that is using oral corticosteroid bursts, because they will get acute relief for severe blockage and loss of smell. The problem, as we all know, is that we can't keep the patient on oral corticosteroids, or for that matter, as we'll talk about, frequent bursts, because of the possibility of significant steroid side effects. Saline irrigation, I think, is also very important for these patients. High volume irrigation, hypertonic seems to work somewhat better. And then as far as antibiotics, again, most of the patients that are having disease with chronic rhinosinusitis and nasal polyps, it is not a bacterial condition, but if in fact you think that there may be some underlying bacterial process, then an antibiotic would be indicated. So this is the exhalation delivery system with fluticasone that was approved a few years ago by the FDA for the treatment of nasal polyps. So you'll notice the device here, it's got two nozzles, one that goes in the nose, but also one that goes into the mouth. And what one does is, in fact, exhales into the mouth piece for the mouth, and that leads to the soft palate closing. That then increases the pressure in that sinonasal area. So when the patient does spray the fluticasone, more of the medication gets deeper to the sinonasal tissues. And in their phase 3 study in 2017, they in fact showed that they were able to eliminate the polyps in 25% of the patients on one side by week 24, compared to 8.7% in placebo, which was statistically significant. They had a statistically significant improvement in SNOT-22. And you can see here, basically a 2/3 reduction in the need for surgery. So this is another option out there for your patient population. Now, obviously, we have surgery, and we do see people that answer endoscopic sinus surgery. And generally, we don't go here or the other treatments I'm going to go to unless standard of care therapy fails. So obviously, this provides complete symptom relief from nasal obstruction, but it's not a cure. So patients have to go back on their intranasal corticosteroids to try to prevent nasal polyp regrowth. Patients need to understand that this is not a surgery that cures the condition. Another treatment that's approved by the FDA in patients that have already had one sinus surgery, and the question is now they are having a flare-up again, is a steroid-eluting implant stent. And this can be done in the otolaryngologist office, placing it in the ethmoid sinus, and it slowly releases mometasone, which again is a steroid, over a 90-day period. And it's been shown to decrease the need for revision surgery about 61%. So that's an option in patients that have had surgery once. So let's come back to John. He was given, in fact, that short course of oral steroids and an intranasal corticosteroid. He reported that the oral steroids relieved his symptoms, but the symptoms returned in the last week. So about 2 weeks, in fact, after stopping oral corticosteroids. He states he has been using fluticasone daily, and the CT scan revealed bilateral nasal polyps with moderate opacification. So now we have our next question. So John presents with these are the options that we would now go to John for the treatment of his condition. So which treatment would you recommend? Would you prescribe the exhalation delivery system fluticasone? Would you give him another burst of oral corticosteroids? Would you now refer him for functional endoscopic surgery? Would you now initiate biologic therapy? So if I can have your answers now. All right, so half the exhalation delivery system fluticasone, that's definitely an option. Prescribe oral corticosteroid again. That in fact, may be an option that we have to be concerned about one burst after another, as I said. Referred endoscopic sinus surgery, yeah, that may be a little early. And initiate biologic therapy. Again, to be honest, I would do shared decision making with him right now and really kind of give him these possibilities and kind of see, his thoughts about these types of treatment. So I don't think there's necessarily a right or wrong answer here. What I do want to mention, though, is my concern again about a frequent burst of oral corticosteroids. All of us know that daily, alternate day oral corticosteroids will lead to significant side effects. But what about burst of oral corticosteroids? So this is an interesting study done by David Price, and this was looking at a very large database that had matched pairs of asthma patients. And they were matched. One was either had a steroid burst and within the next 18 months had another steroid burst versus an asthma patient that did not have a steroid burst and none for the next 18 months. So those were matched. There were almost 25,000 of those. And they had data looking at their records for 8 to 9 years. And what they were able to show is what's on this table here, that in fact, the ones that had frequent bursts of oral corticosteroids, and in this case, what we're looking at is equivalent in most cases to about 4 lifetime bursts, there was already significant increase of typical steroid side effects compared to the group of patients with asthma that had no oral corticosteroids during that time. So you see weight gain here, type 2 diabetes, cataracts, pneumonia, osteoporosis. So the point trying to make here is that a lot of times we think, well, we're just giving this for 3 to 5 days. That's not going to cause any long-term side effects. But in fact, at least there is in this asthma study suggestion that yes, it can. So one of the possible options for John would be biologics. So these are the 3 biologics that have been approved by the FDA, and this is in the order of approval by the FDA. So not that one is better than the other here. So first was dupilumab, which we know targets IL-4 and IL-13. I had showed you on that immunopathology chart. You can see the indication for all 3 of these is pretty much patients with uncontrolled chronic rhinosinusitis with nasal polyps. And you can see the dosing for dupilumab every 2 weeks. There were 2 phase 3 studies, one 24 weeks, one 52 weeks. We'll talk about in a minute. Omalizumab came next. Its dosing is related to the patient's serum IgE level and body weight, which is the same as far as in asthma. So that's why you see every 2 to 4 weeks. And then mepolizumab, the one most recently approved, and that's dosed every 4 weeks. The omalizumab study for phase 3 was 2 24 weeks, and the mepolizumab study was 1 52 weeks. I will say, as you see in the red at the bottom, when you look at the safety of all 3 of these, and I think a lot of us have used these for other conditions such as asthma, the safety has been very good with these particular products, with the highest things we see, things like headache and injection site reaction. So let's look at, on all 3 of these studies, the primary endpoints. And there were 2 co-primary endpoints. One was nasal polyp score, and it scored from 0 to 4 on each side, 0, no polyps, 4 basically coming below the inferior turbinate. All the patients in all 3 of these studies had to have a baseline score of 5. And then the other one is nasal congestion obstruction. And this is graded by the patient from 0 to 3, at least in 2 of the studies, 1, 0 to 10. 0 being no nasal blockage, to 3 being so severe that the patient can't tolerate it. So here we're looking at the 2 dupilumab studies, Sinus 24, Sinus 52. And what you'll notice here is that, in fact, there's significant improvement in the nasal polyp score with dupilumab compared to placebo in both studies, both at 24 weeks and at 52 weeks. And in fact, if you look at improvement, and they measured greater than 2 points, it was 46% of the patients with dupilumab versus 5% with placebo, and that's highly clinically relevant. And the same was seen in sinus 52. If you look at nasal congestion, again, in both studies, the sinus 24, sinus 52, there was significant improvement, in fact, in nasal congestion. I do want to point out on both of them, as you'll notice on sinus 24, and you'll see this on the next study with omalizumab, once you stop the treatment, the symptoms come back, or in this case, the polyps start growing back. So as we just mentioned with the surgery, this does not cure the condition either. But as you can see on the sinus 52, as the patient continued to stay on, there was no evidence at all of any tolerance developing. In fact, the patient got better from 24 to 52 weeks. Okay, so this was looking at the need for oral corticosteroids or surgery during the 52-week period. This is pooled data from sinus 24, sinus 52. And you can see here that, in fact, it was 12.5% with dupilumab, 41.8% with placebo, and this was very highly statistically significant. Now we move on to omalizumab. There are two 24-week studies. And what you can see here, for nasal polyp score, in fact, what we can see here for both polyp 1 and polyp 2, there was, again, significant improvement in the nasal polyp score with omalizumab compared to placebo. As you can see here, when the treatment was added back to the patients on placebo were then given omalizumab, you can also see over 24 to 52 weeks, their polyp size decreased. And then when they stopped omalizumab in both groups, the polyps, in fact, grew back. And if we look at nasal congestion score, again, there was significant improvement with omalizumab for nasal congestion compared to placebo. And they also looked at reduction in need for surgery, shrinkage of polyps, improvement in the SNOT-22. And again, there was significant effect with omalizumab in both of their 24-week studies. And the third drug approved by the FDA was mepolizumab. So we're looking at, over on the left, we're looking at nasal polyp score, so it's a little different than the others. But the bottom line here, and you can kind of see how 1 point, 2 point, 3 point improvement, it was statistically significant. And the nasal congestion, which again was a 10-point scale, again also showed a significant improvement in nasal congestion. So obviously all three of these agents met the FDA criteria of meeting the results of the two primary endpoints. Here's looking at reduction of surgery over the 52-week period. And again, we see mepolizumab did show significant reduction in need for surgery compared to placebo. Now, these are things that are in the pipeline. So there are many other biologics out there, and we'll probably see other type of treatments in the future for this debilitating condition. So one is benzorilimab, and there are two studies. One that in fact is finished is the OSTRA study, and you can see the dosing here. And this particular study was published recently. It did show a significant improvement in nasal polyp score and nasal congestion. Some of the secondary parameters were not that good. The FDA decided that they really needed to see the results of efficacy in a second study. So the FDA did not approve it on one study. And so we'll wait to see the second study, the ORCHARD study, and see what the results are there. Tezepelumab is being looked at for this condition. You can see, hopefully we'll have a study finished in April. And then a drug that's not approved for any condition at this time, and that's demokinumab, is a long-acting anti-IL-5 agent. And we'll see, hopefully in January of 2025, if this particular product has an effect in this condition. So a lot of interesting things in the pipeline. Okay, so when we think about biologic treatments, the question is who, and then when do we use it? In other words, we go back to John, is this the right time to start him on a biologic? So there are many different algorithms out there that have been published on management of patients with chronic rhinosinusitis. And I'm just going to go over 3 of those with you this evening. You'll notice they're not all exactly the same. So there's obviously, the way I talk about it, wiggle room here as far as deciding, and that gets back to shared decision-making with the patient. So in this paper that was published last year that had allergists, otolaryngologists, and others, their thought was a majority of patients should have sinus surgery first, and then, again, placed back on saline irrigation and intranasal steroids. And then if they had a failure there, then they talk about biologics or revision surgery, or if they have aspirin sensitivity, desensitization, or that steroid stent, or consider another short burst of oral steroids. And then for a minority of patients that have contraindication of surgery, or they have significant comorbidity, being poorly controlled asthma, or with shared decision-making, I think this is appropriate to say, I'm not letting anyone do surgery on my sinuses. Then you would go next to consider the biologics out there. So that's one algorithm. This one from Euphoria, which is a European group for allergy and airway disease. It's also made up of allergists, pulmonologists, and others. This was their indication for biologic treatment for nasal polyps. One is the patient has to have bilateral nasal polyps, and then have they had surgery or not? If they've had surgery, 3 of these criteria, if not 4. And I think these are all very good criteria. 1, does the patient show evidence of type 2 inflammation? 2, has there been a need for systemic corticosteroids, 2 or more bursts in a year? Is there significantly impaired quality of life? A significant loss of taste or smell? And does the patient have a diagnosis of comorbid asthma? So that's the criteria they use, and I think those criteria do make sense. And then this comes from EPOS, and EPOS is the European position paper on rhinosinusitis and nasal polyps, which is probably the largest organization of otolaryngologists in Europe. Their feeling is that patients should have surgery first. So in patients that have already had endoscopic sinus surgery, then it talks about 3 of the criteria, which is this is just like the ones that I mentioned for Euphoria. So you can see here there are some differences of opinion of whether surgery should be first line or not. My personal thing, this is CME, is that I think there should be shared decision-making at the very beginning between endoscopic sinus surgery and biologics or the other treatments to get the patient's weigh in to determine what they would prefer for treatment. Remember, none of these treatments cure the condition. So if we come back to John here, he definitely is a candidate for surgery if we use the multidisciplinary consensus. As far as biologic therapy, it would mean, again, if he had a contraindication for surgery or poor asthma control, etc. Euphoria, he does meet the criteria for a biologic because he has the comorbid asthma, loss of smell, need for systemic steroids, and evidence of type 2 disease. And EPOS, he really doesn't meet the criteria for a biologic because he's not had without endoscopic sinus surgery, even though he has the other things. So again, it gets back to, and I think this is the most important bullet, is at the bottom of the slide. And that is employ clinical judgment and shared decision-making in all patients with chronic rhinosinusitis nasal polyps. Here, one size does not fit all. Okay, so let's look at what tends to happen, and we're looking at revision surgery here. So again, standard care therapy, nasal irrigation, intranasal steroids, short-term oral corticosteroids. And what we know from several studies, and this one comes from Galen, which is a research group of otolaryngologists in Europe, about 46% of their patient population requires surgery. And then there have been several studies that follow up patients to see how many would need revision surgery. So one study out of Europe suggested it was about basically a third of the patients at 6 months and 40% at 18 months. And then a very long study out of the UK looked at over a 12-year period. And a third of the patients required repeat surgery and 20% had multiple surgeries. So again, and when you look at these patients, they tend to be the ones, again, that have comorbidities. So with that, how do you determine which biologic treatment? And the first thing I want to mention is there are no head-to-head studies. So I can't tell you 100% that one particular biologic is better than the other. Now, what has been done is people have taken the studies that have been published, phase 3, and have done indirect types of analysis to try to determine if, in fact, one product's better than the other. With the point being is all of these studies enroll some patients with some different characteristics. So again, it's not 100%, but it's the best guide we have right this minute. So this study was published last year in Allergy, looked at things like sense of smell and quality of life, suggested there was better response with dupilumab here in the blue, and a better improvement in the SNOT-22 with that biologic. When they looked at the decreasing the rate of needing surgery or oral corticosteroids compared to placebo, so the lower the value here, the better. You can see that it's, again, the blue bar, so it again suggests that dupilumab, in fact, may be better here. This was by Anja Peters out of Northwestern, which was an indirect meta-analysis. So again, taking the data that's out there, remember, they're not head-to-head studies, and running this particular statistical analysis, comparing the dupilumab data to the omalizumab data. And for nasal polyp score, nasal congestion, loss of sense of smell, it significantly favored dupilumab. So let's look at another patient here. This is Susan, and she's 34. She presents with a previous diagnosis of chronic rhinosinusitis with nasal polyps, and she reports loss of smell over the last 3 months, and she did have confirmation of her nasal polyps. She also has comorbid asthma that's controlled with budesonide. She's had 2 endoscopic sinus surgeries, 2 courses of prednisone in the last 18 months, and she really just comes back saying intranasal steroids just never really work for me. She mentions how bad her sinuses get, that she has to take, when she had to take ibuprofen for recent foot surgery, and she's had to increase the use of her rescue inhaler. So suggestion that she has Aspergillus respiratory disease. And she's coming back to us to request a course of prednisone as the only thing that seems to help her in the past. So this leads us to our next question. How would you treat Susan? Would you give her a short course of oral steroids, revision endoscopic sinus surgery, biologic therapy, short course of oral corticosteroids, revision endoscopic sinus surgery or biologic, steroid sinus implant, aspirin desensitization? So if I could have your answers now. Okay, so we've got two where we have answers. I agree that the first two doesn't sound like the right thing to do for her. Sinus implant is a possibility, and aspirin desensitization is a possibility and does help many of these patients. Biologic therapies definitely can be indicated here. And then a short burst of steroids with revision or biologic. Again, that gets back to shared decision making. So I truly understand that particular answer also. So if we go back to the algorithms we mentioned, so we look at the multidisciplinary consensus, she definitely fits offering her a biologic, a revision, or aspirin desensitization, or a steroid implant, or a short burst. So again, all of those would be appropriate options. Euphoria, she definitely meets the guidelines for a biologic. And if we look at EPOS, because she's already had surgery before, she meets that criteria. But again, we know to, again, employ clinical judgment and shared decision-making, and then find out from her and discuss both the pros, the cons, the outcomes, the cost of these particular treatments. Now, this is, again, from Anja Peter's paper, the indirect analysis of dupilumab and omalizumab, and they looked at patients with nasal polyps and asthma with and without aspirin-induced respiratory disease. And it really didn't matter here. Their analysis by an indirect statistics suggested better improvement with dupilumab versus omalizumab. Again, it's not a head-to-head study. So what are our key takeaways here this evening? One of the things I think that is important here, we have a lot of good treatments. Unfortunately, we don't have a cure for the patient, but we do have treatments that control them. And so it's very important to do shared decision-making with these patients. And the American College of Allergy, Asthma, and Immunology and the American Rhinologic Society, in fact, have shared decision-making tools that physicians can use. This is kind of a summary of one. So you can see here it lists, and it's written in a language, really a fifth grade language, so all patients can understand it. So it's how is it used, advantages, disadvantages, cost. So the patient can get educated on these and get an idea, in fact, if it is some, which of these, in fact, they would prefer to do. Because the reason I think this is so important is, remember, whatever they do, they've got to do chronically. And we know from studies that patients that participate in shared decision-making are more adherent to the therapy and, in fact, therefore get better outcomes. So we're going to move on now and go to our post-test polling. So here is the first question. Patients with chronic rhinosinusitis and nasal polyps and a relevant comorbid condition were up to how many times more likely to undergo at least one revision surgery during a 10-year window compared to patients without a comorbidity? Was it 2.7%, 3.7%, 4.7%? So have your answers now. Okay. So in fact, the answer was was 4.7%. So that was a recent study that was published in Rhinology. And I think this is a very important study and a very important point for this talk. And that is, again, patients that have comorbidities like asthma, aspirin or NSAID exacerbatory respiratory disease, with their nasal polyps, allergic rhinitis, tend to have more severe disease. And that's what this particular study clearly pointed out. Okay, next one. According to EPOS 2020, in order to meet criteria for need of systemic corticosteroids and consideration of biologic treatment for this condition, patients should have which of the following? One or more short bursts of oral corticosteroids or long-term oral corticosteroids greater than 1 month, 2 or more short courses of oral corticosteroids per year or long-term oral corticosteroid therapy for 3 or more months, or the third answer, 3 or more short courses of oral corticosteroids per year or long-term oral corticosteroid therapy for 6 months or more. So if I could have your answer to that question now. All right. So in fact, the answer is 2 or more courses of oral corticosteroid per year or long-term oral corticosteroid therapy for greater than 3 months. And I think, again, that's very important. And when I see that patient that has had 2 bursts of steroids in a year, I know that something else needs to be done. One is because I'm not keeping the patient's nasal polyps under control. 2, as we talked about with the David Price study, we know that frequent bursts of oral corticosteroids over time can lead to systemic side effects. Okay. So let's go to the next question. Here we go. Did I go? Oops, I'm sorry. There we go. Tom is a 45-year-old male with chronic rhinosinusitis and nasal polyps that's impacting his quality of life. He is currently taking medium-dose inhaled corticosteroids for comorbid asthma. He was treated with exhalation delivery system fluticasone for the past 6 months and was previously on daily nasal steroid. He completed 2 short courses of oral corticosteroids after losing his ability to smell. His smell returned after each oral corticosteroid burst, but then it faded away again. Tom is surgery naive. What would you recommend as the next step for this patient? A short burst of oral corticosteroids, inhalation delivery system fluticasone, 1 puff per nostril twice a day, biologic therapy, or functional endoscopic sinus surgery. So if we could have your answers now. So the majority of you have biologic therapy, followed by functional endoscopic sinus surgery, and then the EDS fluticasone. So here's my thoughts about this. I do think it's between biologic therapy and functional endoscopic sinus surgery. This is one of these conditions where I would still use shared decision making, but I would give my opinion here. And that is because he has significant asthma. He's on medium dose inhaled corticosteroids. He has at least moderate disease. By putting him on the biologic, I may in fact be able to control 2 diseases with one treatment. Again, he might not want to have injections, say, every 2 to 4 weeks, and he may opt for functional endoscopic surgery. So I think both are correct, but because of his asthma, I would lean the patient toward the biologic therapy. Okay, next one. A subgroup analysis of patients with chronic rhinosinusitis with nasal polyps and asthma is an indirect treatment comparison found statistically significant improvement in nasal polyp score and nasal congestion in patients with or without aspirin exacerbatory respiratory disease and in patients with nasal congestion with aspirin exacerbatory respiratory disease for which of the following? Was it dupilumab versus omalizumab? Was it omalizumab versus mepolizumab? Was it mepolizumab versus dupilumab? So if I could have your answers now. All right, and I see the vast majority of you got it right. Those indirect analysis that we showed by Anjum Peters were between dupilumab and omalizumab, again suggesting that dupilumab showed a significant better improvement than omalizumab. So in conclusion, the summary, I think that it's important to realize the true burden of this condition on the patient, both on their quality of life and economically. As I mentioned, there are multiple questionnaires to assess quality of life in this condition. And I do think especially the short one that I showed you could be used in a clinical setting. Adverse events of systemic corticosteroids outweigh advantages of therapeutic value in the long term, except in patients when basically everything else fails, severe symptomatology or treatment resistance. Consensus groups, and I showed you 3 of those this evening, provide guidance as selection of surgery versus biologics or other treatments for chronic rhinosinusitis and nasal polyps. As I mentioned, there are 3 approved. There are several in the pipeline as far as biologics for this condition. And again, in the absence of head-to-head studies, which we don't have, indirect treatment comparisons may provide some support for selection of individual biologics in individual patients. Presence of comorbidities, such as asthma, aspirin exacerbatory respiratory disease, should definitely be considered when we're thinking about treatments in patients with nasal polyps, especially again leaning toward a biologic. And as we mentioned a few times, patients with chronic rhinosinusitis and comorbidities had up to a 4.7 times more likely to undergo revision endoscopic sinus surgery. So we really need to remember these are some of our worst patients. So I really hope this evening I've been gave you a general overview that will help you in your clinic setting for these particular patients. So with that, we're going to move into our question and answer session. So again, you can type in your question, and I will definitely try to answer it for you this evening. Any questions? Happy to try to answer anything for you related to the subject of chronic rhinosinusitis with nasal polyps, or clarify anything that I covered this evening. Okay. Well, I don't see any this evening. I hope that means I've clarified through the lecture every question you had about this condition. So I want to thank you for attending this evening. I really appreciate it. As we mentioned, this is CME, and to receive your credit, be sure to complete the program evaluation. You can see the site here, integrityce.com/allergyeval4. So it was a real pleasure to speak with you this evening, and hope to